Next, I would like to invite Dr. SUNEETA to give her talk. Questions can be taken at the end of all the sessions. Thank you.
So at the outset, I would like to thank Dr. Mahesh for giving me this opportunity. I'll be talking on ab internogoniectomy with trabectome. So if you look at this glaucoma management spectrum, MIGs were designed to bridge the gap between medical and laser therapies and more invasive filtering surgeries in mild to moderate glaucoma, especially when the patient is undergoing cataract surgery or when the patient has developed allergy or is non-compliant to the treatment. So MIGs can be classified based on their physiological mechanisms and anatomical site of action. And in India, we have been doing the procedures, the Schlemm's canal and trabecular bypass procedures and various types of trabeculotomies. And the mechanism of action is to target the site of maximum resistance and thereby increasing the outflow through the conventional pathway. So TM and inner wall of Schlemm's canal at the site of maximal resistance, and the maximum concentration of the collector channels are present nasally, and it's better to target this area. So I'll be mainly talking about Trabectome, which was approved in 2006, and it's a stand-alone device, and it utilizes a controlled plasma-mediated ablation system and achieves complete removal of the diseased trabecular meshwork and inner wall of Schlemm's canal. Since it's a excisional goniectomy, it minimizes the chances of scarring and reocclusion of the collector channels, as the remaining edges of the TM are far apart, as you can see here. And it incorporates, the biggest advantage is that it is associated with the irrigation aspiration system, and that definitely helps in the initial stages to increase intraoperative visibility as it pressurizes the chamber and maintains the anterior chamber and also manages the blood reflex. The foot plate, which is there, it helps guide the electrosurgical tip and also protects the adjacent tissue, so the collateral damage can be prevented. It can be there as a probe which can be attached to the phaco, so phaco compatibility is also there. So it can be used in all types of glaucomas, even in narrow angle glaucomas after a patent PI, and even in congenital glaucoma. And Dr. Mahesh has already discussed about the position and setup of the patient for any goniotomy procedure. This is the animation video wherein a 1.8 millimeter clear corneal incision is made, and the viscoelastic is placed over the cornea. It's very important to verify the angle view before starting the procedure. And this is the probe with the tip, insulated tip. The irrigation is coming from the side and aspiration at the tip. And this is the active electrode for the ablation and insulated foot plate. So once you introduce the probe inside, you engage the trabecular meshwork and then start ablating in one direction along the arc of the Schlemm's canal, and then rotate the handpiece and ablate in the opposite direction. So as has already been mentioned, it will go very smoothly if you are in the right plane, and you will not feel any resistance, and then the irrigation and aspiration. So as with other mixed procedure, it is always good to combine the procedures with the phaco, and again the procedure is performed before phacoemulsification. Identification of the angle is done, and then the incision is given, and with the probe visualize the trabecular meshwork and then engage it and just rotate it and ablate the TM and inner wall of Schlemm's canal in one direction, and then reverse the tip and do it in the other direction. And as you keep rotating the gonio prism, as you can see here, you can target almost 160 degrees of the angle. And here, after completion of trabectome procedure, you proceed with the phacoemulsification. And in all these procedures, if you see this fluid wave at the end of the procedure, when you form the anterior chamber, you see this blanching of the blood vessels, and this ensures that you have made a good connection between the anterior chamber and the collector channels. So this is to ensure. So there are various studies which have shown the efficacy of trabectome, and this was the first analysis wherein almost 5,000 trabectome surgeries were analyzed for a period of 90 months, and they assessed the survivability of patients resulting in IOP less than 21 millimeter mercury, and at least 20% reduction in the baseline IOP and no additional glaucoma surgeries. And the results were that it was the survival analysis was done, and 66% success was achieved in trabectome alone and 85% in phacotrabectome. And it was concluded that it lowers the IOP by approximately 36% while decreasing the number of medications by less than 1. Trabectome also works after failed trabeculectomy because collector channels do not atrophy completely. So one can also do trabectome or any angle procedure even after failed trabeculectomy or implants. So I'll just in short about our data. We did, it's going to be published in IGO. So we did 58 patients and we followed them up to 1 year, and all types of glaucomas were included, including congenital glaucoma. So I also included about 35% of severe glaucoma. The trabectome was done alone in 8%, and combined with phaco in 42% patients. And there was significant reduction in the intraocular pressure, which was very statistically significant, from 24.4 to 14.6 at the end of 1 year without phaco, and from 16.6 to 13.4 with phaco. And there was reduction of AGMs by more than 1, and this is the survival analysis plot. So the individuals undergoing trabectome and phaco had 88% survival at the end of 1 year, and with trabectome surgery alone 67% survival. So just 1 or 2 cases, it is very effective in patients with pseudoexfoliation glaucoma and pigmentary glaucoma. So this patient had undergone phacotrabeculectomy in one eye. Pressure was 10 millimeter mercury. The other eye had 24 millimeter mercury pressure. She was on 2 AGMs and with significant cataract. And this is the visual field. And this patient had very good reduction of intraocular pressure at the end of 6 months with no medications. Similarly, in patients who have high risk of hypotony after trabeculectomy, in patients who are young myopes, this procedure is quite beneficial, and this is a young male myope with pigmentary glaucoma. He underwent trabeculectomy in one eye having hypotony, and the other eye I did trabectome, and you can see the cleft, beautiful cleft, and the pressure reduction was remarkable. In congenital glaucoma, this patient, the child who underwent bilateral trap plus trap, one eye was controlled and there was no progression, whereas the other eye, the axial length increased and the bleb got scarred and showed signs of progression. So in this particular patient also, after failed trap plus trap, the angle procedure trabectome was performed, and you can see as you ablate the trabecular meshwork and the inner wall of Schlemm's canal, you can see this outer wall of Schlemm's canal, and this white line can be seen. So this patient did very well. So you need to choose the appropriate candidates, as had already been discussed by Dr. Mahesh, that initially when you start the procedure, the angle should be open, and learning intraoperative gonioscopy with proper visualization of angle and working under high magnification is very, very important. Proper wound construction, avoid limbal vessels while maintaining the chambers, and whenever you are doing any angle procedure, ensure that you are in the right plane along the arc of the Schlemm's canal without any resistance. If you feel any kind of resistance, reposition your probe and do it again, and proper post-operative management. So there is definitely a wider scope for these procedures in the coming days. Thank you very much.
Thank you, Dr. Suneeta.